Thanks, Steve. All right, welcome everyone. I'm glad you're here today, and I love talking about contingency management. It's one of my favorite things to talk about. Brief introduction. You saw I've been doing this for a year, and you might think, well, gosh, that's not very long, but contingency management, despite having a very long history, does not have a long history in Colorado. And I'm waiting for slides to pop up, Steve. Thank you. All right. And let's go to the next slide. Okay. All right, and you can, yeah, perfect. Thank you. I also see there's a question about feedback. I am not personally getting any, only we can see your questions, the panelists, but headphones usually help with feedback. All right, and so if you're wondering what contingency management is, as I mentioned, it's got a very brief history in Colorado, and we can cover all that in just a minute, but it's behavioral therapy in which individuals get reinforcement rewards for positive behavioral change. So what does that mean? Usually we can make this tangible. And so the reinforcement or reward is usually financial, or something very close to financial, like a gift card. And often that gift card is it's pretty useful. So it's something like Walmart, it's not niche purpose like a candle or a massage or something like that. As much as that sounds cool, it's usually money. And the positive behavioral change often is biologically proven abstinence from certain substances or all substances. And to get even more specific on that, often that's a urine drug screen, but it could also be something like a cheek swab. You generally wouldn't use like a hair test or something longer term. You want something that's pretty short term. And so the reason this works is, yes, also want to know that even though they spelled behavioral wrong on this slide, it's still valid. Let's move to the next slide, and we'll talk a little bit more about the neurobiological underpinnings of this. So operant conditioning, I think most of you are clinicians, so this brings me back. I'm not a clinician or doctor, but definitely brings me back to psychology courses in undergrad. And Pavlov's dogs, I think that was classical, but operant conditioning, you're essentially, and this is one of the criticisms of contingency management, is you are hijacking someone with substance use disorders penchant for rewards, and immediate rewards, right? Because people who have substance use disorder have extreme delayed discounting. They don't value things in the future. Right? I mean, if you offered someone an 8-ball today or 3 8-balls tomorrow, most of them would probably go for an 8-ball today, even though that's a ridiculous trade-off, right? And so you're working against that as you do counseling or any type of medical or therapeutic intervention with people, because they just don't see benefit in anything beyond right now. And really, a lot of them don't see benefit in anything that's not at the very base of the pyramid of Maslow's hierarchy of needs, right? Food, shelter, drugs, sex, those are really salient things for people. And what else is salient is money. And so you're using something that's a little more societally acceptable, a little more sustainable, a little less harmful to replace the dopamine, the rush from substances. And so, yes, you're replacing substances with money temporarily in order to move people further along, or further up the pyramid, right? You're moving more toward good relationships, rewards from having a career and things like that. And so in that sense, yes, you're replacing one thing with another, but it's healthier, it's less harmful, and it's on the way to other positive interventions, things that you might gain through something like community reinforcement approach, right? As people transition from substance use into work, back into enfranchisement in the community. All right. And so this, contingency management really works for substance use disorder. And as we'll see on some other slides, I want to emphasize more than once that it works for all types of substance use disorder. And so recently, there's been a lot of focus on this for stimulant use disorder, as you see here in my third bullet point, that there are health issues without pharmacological solutions. So we tend to put opioid use disorder in, oh, we've got Suboxone, we've got methadone to help to ease cravings, maybe help people back into the healthcare system. Stimulant use disorder is really absent those interventions, despite some recent studies that show there might be some somewhat effective drugs for stimulant use disorder. There's nothing that really works as well as, say, buprenorphine or methadone. And also alcohol, not great pharmacological solutions for that. And so this is something that can work as an adjunct pharmacology or on its own for stimulant use. But to be clear, the evidence shows that this works for all types of substance use disorder, including, it's really big for nicotine actually also. Next slide, please. Okay. So what is contingent management? A little bit to elaborate on the first slide, very evidence-based. Again, one thing you're going to hear me say the important things over and over, evidence-based. I don't often use that because I think it gets overused. This is a very clearly evidence-based program. And I don't call it treatment because even though it is treatment on its own, it's often done in tandem with clinical treatment. It's really not treatment in that it doesn't need to be provided by a licensed clinician or other healthcare professional. You can have a paraprofessional or even administer this in a recovery or a WIC clinic or some other type of setting. But it is a practice and it's highly evidence-based. It's so evidence-based, we're going to go into detail on how evidence-based it is, but I would put it up there with anything else. In fact, I would put it above things like CBT, even opioid use disorder. As far as cost benefit ratios, there's some studies that show this is the most evidence-based thing you can do, other than prevention. Once you get into the treatment or recovery phase, this is really it. And I want to contrast that with the low implementation. So I mentioned that this has really not been implemented in Colorado or really around the country. And what got that started off, where you might have heard of it, other people heard of it, is New York Times, I think December 2020 or so, did a big article on contingency management for stimulant use disorder and the lack of implementation compared to its effectiveness. Boston Globe has followed up with a big article. And now you've seen this in Health Affairs and other various journals highlighting the disparity between implementation and effectiveness. And so it provides tangible incentives for desired behavior changes. The studies go into diverse settings, community health centers, community mental health centers, residential settings, like I said, non-treatment clinics like WIC clinics, all types of substances, nicotine, stimulants, marijuana, subpopulations, men who have sex with men, BIPOC people, just all over the map. The studies show that this works really, really, really well. And it's usually over 3 to 6 months. Some of them go a little bit longer. Most of the studies in clinical, like people's experiences with this, show that less than 3 months doesn't give you long enough for people to really learn the association between abstinence and positive outcomes. That is that they don't really get it the first month, so they try to cheat and stuff like that. And you need an additional few months so people start to identify even short-term abstinence with positive outcomes of money. And as I said here, it often coincides with individual group IOP treatment. The programs where we're helping to implement it, often they start in an IOP, they start in a limited setting. It also helps because the groups help give feedback to people. So people get a reward, the group says, yay, way to go, and they get that additional bonus of and feeling good, positive peer responses in addition to the money itself. And so then we've had some programs move it into individual settings, particularly Denver Health did this around COVID when they couldn't do groups. So it's definitely done in all these settings, but often people start it with the higher acuity IOP or group settings. And feel free, perfect, just as I said this, where does the money come from? That's a great example. Banks is really the answer, right? That's where the money is. But we'll talk about that as we go on. We're going to go through kind of clinical practice. How does this work in a clinic? And then we'll go into some of the regulatory administrative barriers and enabling factors. And then we'll go into where to get money for this, particularly in Colorado. And so you've got to, this is one of those where we've done a lot of work on this. You've got to kind of poke around. Depends what kind of provider you are. If you're commercial, commercial Medicaid, it's a little bit different everywhere. So this is where we've gotten really good at finding little pockets of money to start pilot programs. But ultimately our goal, Joanne, is that commercial and Medicaid plans cover this. And in fact, both of them covering it's really important because most providers do have both types of clients. And so that's the end game. And I know that's a big goal, but the reason why I'm optimistic about this is that it's actually cost beneficial, as we'll see on some of the slides. You actually save money because people don't have to go to residential. This prevents a lot of residential or detox admissions, which cost a lot more than these pretty small incentives do. And you mentioned, what about unresolved trauma that often leads to relapse? Again, this really deals with people at a very base level. It certainly doesn't, giving people money for substance use disorder doesn't resolve trauma, and that's where coterminous asynchronous clinical counseling really helps. Right? It just like opioid use disorder medications, that just helps with my cravings. It doesn't help resolve any trauma, doesn't help me have better relationships with my employer, better relationships with my family, right? So that's where clinical and adjunct help, like CRAF, community reinforcement approach, and recovery services come in. So, not a standalone, can be a standalone program, but also works in conjunction with clinical and non-clinical professionals to help with things like trauma. Next slide. All right, so now we are getting into the money. And so there's no upper limit to effectiveness here. In fact, they've gone up to about $1,500 per program, and it works better. More money works better, which is not surprising. Most programs stay under the taxation limit. So if you go over $600 a year for this, you have to issue people tax documents. You have to issue them a 1099. And most people don't want to receive those. They don't want to pay tax on this. Most places don't want to issue these. So a lot of programs just somewhat arbitrarily set their program limit at about $550. So $599 in some cases. And that produces really good outcomes. Much better, statistically significantly better outcomes than smaller incentives like $200. And again, that's over about 6 months. It's about $100 a month for a big program, which I think, we'd all agree in the context of behavioral health and treatment is really not that much. A lot of IOP programs run about 200 a session. So that would be 600 a week. So, this is really a small amount compared to IOP, and certainly a small amount compared to detox or residential. One thing to know, if you try to do this with a really small amount of money, it gets ineffective. And so we actually won't work with programs if the money on offer is less than about $200. And we'll talk about why do programs want to do that. A, it does cost money. B, there is a bit of a myth that you can only go up to $75, and we'll deal directly with that in a few slides. The best studies use cash or cash equivalents. So they use something like a debit card. Most places don't actually use cash. They use like an account deposit, a prepaid debit card. Some places use very widely utilized gift cards. So that would be like a big chain grocery store or a box store, because you want everybody to want these and value them kind of like money. If you start to get into really niche retailers, they become less useful to people. So if you give, and also talking to actually a person in recovery who had been through a program like this, he was in community corrections and they gave stuff for good behavior. Great, right? His stuff was movie tickets, and his program, he could work 9 to 5, otherwise he had to be at home. So his movie tickets really didn't do him any good. And so that's just a microcosm of why having something that's more broadly applicable allows people to make choices, right? They can buy diapers, they can buy propane, they can buy a coat, they could buy movie tickets if they wanted to. And one of the keys here is that you do this immediately. upon displaying desired behavior. So the closest we can get to that is they come in, you do a urine drug screen, it's negative, and you say, great job, here's your money. And it loads onto their debit card, and they can see that and they can spend it immediately, right? Because as we discussed, a lot of delay discounting, if you say, oh, you said you didn't use, great job, now we're going to send off this lab and in a week you'll get your reward. People don't associate that short-term abstinence with the reward, right? So the closer you can associate the behavior and the reward, the better it is. So some people actually add on little incentives like $5 just for showing up to, say, like a counseling visit or a group, because people see, oh, I got here, I get a few dollars. Next slide. All right. So I have a obligatory quote here, and so they do use these in some big treatment settings. Like I said, Denver Health locally is really the biggest one. They were the originator of this, and obviously they find it very valuable. They've kept it up. They self-fund theirs, I think, through donations and through departmental money. But a lot of places are looking at different ways to fund this. But the fact that people self-fund it obviously shows you that it works and that they get more attention, and people show up. And so they make it work in a self-sustainable way. And there are a few other mostly commercial clinics in Colorado. And when I say commercial, I mean places that accept commercial insurance or self-pay that do self-fund this now. I think 2 or 3 others that I know of have picked this up now. All right, next slide. Okay, quizzes. Feel free to put your answers in the Q&A or just keep them to yourselves. And I do want to thank David Gastreen, who helped me out with some of these slides. So think to these, write it down. What % of U.S. treatment programs report using contingency management? Second one, what places, like what types of treatment programs do they use these, if you know of any, and how good are they? How much do they help? So I'll give you a minute to write down your answers to these questions. Questions are always helpful to keep people engaged. You can also put your questions in the Q&A, and I'll try to answer those. But I think you've had a little bit of time to answer these, at least in your head. So let's move on to the next slide. Okay. So you see there, small minority, and it's actually smaller than this. I think they use a really broad definition of contingency management here. And so if you think about this as any reward for any good behavior, a lot of opioid treatment programs or methadone clinics use this, because when you are absent from illicit opioids, you get take homes. And so that is a reward, right? So if you count that, then contingency management is a more widespread practice by far. If you talk about just gift cards or money, I think this number is somewhere like 1 or 2 or 3%. It's very, very rare. I think there's also some residential treatment programs that do a token economy. They often do this in a community corrections residential treatment after incarceration setting, where people get t-shirts or candy bars or something like that. But if you really limit it just to gift cards or money, this is a very small number. So second, you might wonder, hey, these are really effective treatment locations, right? People identify physician health programs as the gold standard for treatment often, and drug courts, right? And so no coincidence that these are effective and they use an effective treatment of contingency management. So physician health programs are routinely quoted as having, 80, 90% success rates, as you see down at the bottom. Having been through one of these myself, I don't know if I believe that it's 80 or 90%, but it's really good. You know, the majority of people do rehabilitate their license, and many of them stay absent or have very huge reductions in their substance use over many years. And I was a product of one of these. I have some feelings about it, but it definitely worked because there's accountability. There's additional privileges as you do better, and that's contingency management, right? They definitely didn't give out any money. In fact, PHPs cost a lot of money for most people. But drug and DUI courts often do token economy. They give people rewards, tangible rewards for doing better. And they also, all of these also offer praise. And so I don't want to sell that short, that having a caring clinician or other personnel overseeing this, motivational interviewing is really helpful, because sometimes people don't get rewards, right? And they need to stay in the program. So making sure that you talk about the good things is really part of contingency management. It's a great place to use motivational interviewing. All right, next slide. Okay, so this is some of the evidence. And again, thanks to Dr. Gastrine for this. Huge changes from pretty big. I think the far left and the far right are pretty big studies. The middle one's a pretty small study, but the two on the edge are really robust studies. And these are different types of substances. As I mentioned, contingency management really effective for all substances that has been studied. A big one is stimulants. You see that over on the left. I think this was mostly cocaine. This was 2006. I think it was East Coast. So it was probably mostly cocaine users. And huge increases in abstinence from a very difficult to treat condition of stimulant use disorder, and almost tripling the abstinence rates. And then in the middle, you see huge amounts of, or a huge reduction in drinks per month in that smaller study. And then over on the right, tripling of smoking quit rates. Again, really difficult condition to treat. And I'd also point out, you might say, oh, these are still small numbers on the left and the right. These are complete abstinence. So how many other people reduce their use in those groups? Probably a lot. And so, contingency management does reward abstinence, but it's by test, right? So you don't have to be abstinent for 3 months to get the rewards, right? It's short term. So if people can stay abstinent for, one drug test, 2 drug tests, that's how you start to get days, and you start to get weeks, and you start to get months. So even these small numbers are really, really promising. And these have been shown in every study that we've looked at. Numbers were replicated, and people engage in more pro-social behaviors and reduce their substance use. So the evidence is really, really incontrovertible that contingency management is extremely helpful. Next slide. This is a little bit more in different populations, different treatment settings, dual diagnoses, people experiencing homelessness. So, really patient populations that are typically identified as difficult. I don't like to call people difficult, but patients that are hard to retain in treatment. You get retention because money helps retain people. Money is salient for people who have dual diagnoses, people experiencing homelessness, people leaving the criminal justice system. And they've also done this in pregnant people. There's actually the first ever digital therapeutic just for contingency management was for pregnant women. In fact, I think the first 2 contingency management apps were approved by the FDA for nicotine use in pregnant women. So they're used for other things too, but that was the FDA approval. And adolescents, right? Who needs money more than teens? And they're also very sensitive to prices and money. And so this works really well for adolescents. Next slide. All right, so cost benefit. So evidence, there's a lot of effective treatments out there, right? But when you talk to payers who you want to reimburse you as a provider for something, you need to show them that it's beneficial to them, that they're going to save money. And this is the key slide for that. It's the key. If you want to approach any payer, this is where you start. And we're starting negotiations with several payers on this. And when we say, it saves 50 to 1, they sit up and take notice, right? Because they're used to hearing this is effective, this works really well. But when you look at it from cost benefit ratio, people either don't have the data or it's not as good. Here you see how effective some of our treatments are. CBT, motivational interviewing have huge returns on investment for society. And a lot of that is preventing incarceration. But even at the payer level, contingency management pays off really well. I think the payer ROI is something like 5 to 8 to 1. So when a payer puts $500 into incentives, they get $2,500 to $3,000 back in reduced costs for, again, residential detox, other types of treatment. And so you see, there's a lot of things with really high ROI, and contingency management is by the studies I've seen, and you can go to this Washington State Institute for Public Policy, it is the only place I know of that really compares cost-benefit studies. Contingency management is at the top for substance use disorder. All right, feel free to put any questions in the chat. So now we're going to get into the barriers, and Joanne will move into where to get money after the barriers. So barriers they're the reason why most people don't do this, right? I spent about a year trying to figure out why no one did this, despite all the evidence that it works, and it works in a cost beneficial way, and it works for different people and different types of substances, and came down to these four. We distilled this down. So these are my ideas. It's not from research. It's really just talking to people. We interviewed a lot of peers, a lot of clinicians, a lot of executives on why they don't do this. And we came down to these four. And so number one, the most common one that everyone says, so this was peers, people on the street, executives, there's this mental, this belief you shouldn't pay people for doing what they should do anyway. That's a great point. And honestly, this is the barrier I have the least defense for. Other than, my only defense is that it works, and nothing else works very well, or doesn't work as well. And so if you are very rational, contingency management is really, 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 if you're very utilitarian, contingency management is great. If you're very moralistic that we need to punish people for substance use, contingency management doesn't make a lot of sense, and that you're giving people money to do something that, most of the world is doing already. And so a reminder that it's just temporary, it's not forever, and that it works really well. Second one is that cash might lead to misbehavior. This is really common. I hear this from, clinicians, doctors, people who are aware of evidence, and even people who are very progressive folks worry that they'll get cash and they'll use it for drugs, right? Especially if we're using something like gift cards, they could buy alcohol, they could buy cigarettes. So a couple things on this. Some of the gift and debit cards, I know that Walmart has a gift card that you can't use on alcohol. There are also some specialized debit cards that don't let you use their debit card at liquor stores, strip clubs, other agents of vice. And so there's some ways to protect against that. I think the big thing to remember here is how contingency management works. It actually works because people learn, right? They learn, if I do this good thing, if I abstain from substances, I get money. This is just the counterpoint to that. Say you abstain from substances, you got some money and you went out and blew it on meth. The next time you wouldn't get the money, right? So you would learn, it's part of the learning process. If I do this, if I use drugs, I don't get money. If I don't use drugs, I get money. So it's actually part of the learning process, and it's really understood and very, very, very routine that people don't get 100% of the incentives. They use at some point, and so that's that's really part of the program. Is that people get cash and they either use that money or some other money for substances. It really doesn't matter if the money is from their reward or from their job or whatever it is. But that's part of the learning. Third is more logistical. How do you transfer this to people securely? Most places don't use cash. In fact, I've not heard of anybody using cash. A lot of places do use gift cards, which is a little difficult in that your staff could find their way to those gift cards if they're not well secured. Also, it's harder to trace, right? The gift cards are given away and you might write it down somewhere, but there's no linkage between that person. And say they lose the gift card and they say, I lost the gift card. There's no way to reimburse that. Some of the electronic debit cards do allow for replacement debit cards if people really do lose them. There's also a better paper trail. So we prefer using electronic debit cards either just for contingency management or for clinical trials, because we get better reporting. Also, we get better data on how much incentive are people getting, and people can replace their debit card. And so there's a few organizations that do this, not a whole lot. There's really 3 or 4, I think. 3 of them are contingency management specific, and then one of them has actually clinical trial software. So the 4th one is limits on incentives. So I mentioned earlier, some people believe that $75 is the limit on incentives, and I've heard this over and over and over and over and over. And there's some truth to it. So this is not just a myth that got perpetuated. There is a SAMHSA, so Substance Abuse and Mental Health Services Agency, and HRSA, Health Resources Services Administration, limit on any of their grant dollars that you can only use $75 per person for incentives. So why are those 2 organizations such a big deal? SAMHSA does block grants, they do SOR, they do lots of discretionary grants. So a lot of, if you're in publicly funded healthcare, Medicaid, really, Medicare, there is a lot of truth to this, in that if you're grant funded, your grants very well may come from SAMHSA, they may come from HRSA. Other organizations like Bureau of Justice Assistance actually don't allow any incentives. So there are some limits to incentives, but it is grant or payer specific. So OIG, Office of Inspector General, the overall kind of spending guru for the federal government, has no limits. So there's no blanket limit on incentives in Medicaid, Medicare programs. And in fact, there's no ban on incentives in Medicaid and Medicare programs. There is it's not a lengthy list. There is a list of conditions to provide incentives to avoid fraud, waste, and abuse, and inducement and kickbacks. And so if you're going to start a program, you need to make sure that you're not doing something that could be viewed as inducement or kickback. And there's lots of documents online. That's a lawyer thing, asking about fraud, waste, and abuse, kickbacks. The biggest things I can say are have a treatment plan. So that this needs to be part of the treatment plan. The person will abstain from a substance, and you are paying for those outcomes only when they happen, right? So this can't be part of well, we think you did good this week, and so you get some money. You want to not advertise this. That's generally a good rule. You don't want to advertise incentives because it looks like you might be trying to pull people away from other providers. And then the third big way to prevent kickbacks and inducements are inducements. So I think that those were the 2. Avoid advertising and make sure it's tied to a treatment plan. But again, if you're going to start this, I would talk to your general counsel or your lawyer. There are big law firms that will actually get dispensations from the OIG specifically for really big programs like national programs. Smaller programs generally have read some of the OIG guidance and felt at ease with that. So feel free to put your questions in the chat. I'm not seeing any right now. Briefly, we talked a little bit about what's not permissible. And so I'll speed through this one so that we have some time at the end for Q&A. But the big things are, like I said, preventing fraud, waste, abuse, kickbacks, inducements. You need to have really good protection against fraud. So you need to have, urine drug screens, some proof that people are accomplishing the outcomes. They say here, proof that all your money is going into gift cards and to patients and it's not being frittered away. Don't advertise patient incentives. That's a big one. You can talk in general about a contingency management program. You can definitely talk to your patients about it. Putting it in the paper or online, probably not a great idea. And again, the big one up top, I forgot this one. Doing something that's going to increase your reimbursement is a no-no, right? So retaining people in current treatment, fine. Giving people lots of drug tests because your contingency management program requires it, that's a bad idea. So if you're going to get reimbursed for those drug tests, and contingency management is just a way for you to do more drug tests, that's not a good idea. It's obviously part of waste. Next slide. All right. This is a quote from somebody really important. They say that this is the most effective currently available treatment for stimulant use disorders. I think you saw a couple slides that bolster this. Next slide. All right, what is permissible? This is way too many words to be on a slide, but it's from an OIG document. So there's actually an OIG document that tells you what you can do. And the big thing at the top, as you see, it's the direct connection of coordination and management, right? So abstinence from substances needs to be a goal, and that's what you're reimbursing for. That's actually come up a lot during COVID. People have reimbursed for COVID shots. There's court cases about reimbursement for adolescent health visits. And when I say reimbursement, I mean incentives. And so incentives on the whole are permissible. They just need to be really well tied to coordination and management. Okay, they do say specifically this can be done through remote telehealth apps, digital health technology for contingency management. Third one, we talked about that. Payers only paying for desired outcomes. Abstinent drug test is a big one. I have heard some lawyer types have a problem with attendance alone because they worry that you're just trying to drive up attendance at your behavioral health visits and paying people for that because you get reimbursed for those behavioral health visits. So people really like the abstinent drug test here as far as staying clear of any fraud, waste, and abuse or inducement. And then the last one just talks about that advancing goals, right? So this could be, say, adherence to a drug regimen. This could be an adjunct for people to take their buprenorphine all the time, right? So a positive buprenorphine test would result in a positive buprenorphine test or negative illicit opioid test would result in an incentive. But most of these are abstinence from stimulants, cannabis, alcohol, other opioids. Next slide. Okay, so this is a big slide I've been waiting for to announce this for a long time, and it still hasn't happened. So for our Medicaid-focused clinics, this is a really big deal because a lot of them are getting grants through, as I said, HRSA or SAMHSA. We thought, I think everybody in the policy field thought they were going to change this limit. SAMHSA was going to change this limit sometime this summer because there's a lot of grants called state opioid response grants that just started a couple months ago. We all thought that they were going to change this limit for this round of state opioid response so that people could use it on contingency management. That has not happened yet. And I've talked to some DC type folks and they still think this is going to happen, but there's some holdup in the federal bureaucracy. And so everyone thinks this is coming. And then you would be able to use, if you have any discretionary SAMHSA grants like MAP PADOA, you could use that money for incentives. If you had SOR grants, if you had block grants, you could use that money for incentives. That said, not all money is SAMHSA money, not all money is HRSA money. If you're using your own money, there are state grants here in Colorado, like 202, that have no such prohibition. ARPA money does not have a prohibition. That's American Recovery Plan or COVID relief funding, does not have a limit on incentives. So a lot of state-based money doesn't have this limit. Next slide. Okay, this is just a little bit about our project here in Colorado. So we met with a bunch of people and our goal was to move people from pre-contemplation to contemplation or contemplation to preparation as far as starting their program. So we met with people who lived experience, peers, we met with providers, we met with government payer types, and did in-depth interviews with them. That's how we got some of that information about the barriers. And we also just wanted to get people ready to do this. We had a ton of people come to our initial webinar, and then quite a few people come to webinars on medical and clinical effectiveness and legal and regulatory policy. So actually this webinar is a combination of all three of those. So you're getting the best of all three of those webinars. And we had a lot of people participate. So a lot of people are interested in this. I wrongly predicted 2022 as the year of contingency management, but I am again predicting 2023 as the year of contingency management. I'm hoping that SAMHSA cap on incentives will get raised. And I also think people are starting to learn about this. And there are a lot of other reasons in Colorado why I think this is going to become big, because I think payers are going to start reimbursing for it. And providers have a hand in that too, right? Providers can bring proposals to payers and see if they want to engage in them. And I won't get into it, but there's a lot of reasons that payers might be interested in that this year. Next slide. All right, so these are lessons from those interviews and those talks with folks that we've still got myths and stigma. A couple of those that I want to highlight that are not true. There's a myth, and I heard this just yesterday, that contingency management only works for stimulant use. It works for everything. Stigma around it, definitely still some stigma. But another myth is that myth about the $75, right? That is true for certain grants, but not for everything. Education, this is another one that we need to work on. It's not cash. So a lot of people think that you're handing people cash. It is always gift cards, and preferably it's something traceable like a debit card, a reloadable debit card. There were some challenges, and we got these a lot from people with lived experience. They were worried that, if one person was eligible for the program and somebody else wasn't, there would be jealousy, or someone would leave treatment. And so that highlights the importance of rolling this out to as broad a range of programs and clients as possible. So we've really tried to rapidly move from stimulants only to stimulants and opioids, and even in some cases, stimulants, opioids, and alcohol, so that you're able to do this for all clients. We're still really limited on, most of them are just one payer, like Medicaid specific. So that's important that you're able to try to get it to as many of your patients at once. So there's not like a misunderstanding about why someone got incentive and someone didn't. Eligibility, I just kind of talked about that. Some people really want to focus on the stimulants. Some of this matters how much money you have for it, right? You might need to limit your participation. A lot of promise in moving contingency management outside of treatment settings. We've really try to work with criminal justice affiliated organizations, so like community corrections providers, recovery community organizations, so that this doesn't have to be just people participating in clinical counseling, because some people aren't ready to do counseling. Great way to keep people engaged. That's probably the number one thing we've heard, is that people stay. And finally, there's got to be a standardized policy protocol for this. We do have one of those. We have like a template policy and protocol for this that people can edit to their heart's content, because I know that's something everybody wants, policy and protocol, right? And so we just give them a start to that, and that's available for free. So these are our big lessons learned. We learned that it's great. People really like it. There's still a ways to go. Obviously, the lesson learned that's not on here, that's too obvious, is people need to pay for it, right? Most places aren't going to start this up on their own. So we need payers, Medicaid and commercial providers, and also, private grants, different ways to pay for these programs. And that's something we're really working on developing, both in Colorado and other states. Next slide. All right, so this is just what we learned from our survey. People do want some technical assistance on this. Billing and reimbursement. The note I have on that is that this is not yet billable. Like, there are codes in theory. Virtually no one accepts them yet. And it's still kind of in its infancy, that there are now codes for both reimbursing providers for their time and also for the incentives themselves. So that will be coming. It's not ready for prime time yet, and no one's really accepting them yet. So that is definitely hoping something in 2023. Right now, it's kind of grant funded for the most part. And so it's off. It's not a claims-based program yet. Clinical effectiveness. I don't know how much better it gets than the slides. We have a little white paper on this, but it works everywhere for every substance. Remote options for contingency management. There are 3 companies I know of that currently do this in no particular order. Those are Paratherapeutics, Q2I, and Dynamic Care Health. They all have some version of contingency management, and I believe they're all done remotely. General webinars, this is it. And so I think the big things from this slide, we're learning more about this billing and reimbursement. People want this to be a reimbursable, code-based, like claims-based service that they can, kind of put into the box that they have all their other services in, because otherwise this is outside of what, how you normally deliver clinical programs and get reimbursed for them. All right, next slide. Okay, and so where does the money come from? Great question. Oh, sorry. Yeah, so these are, if you're outside of Colorado, these are probably totally foreign words. If you're in Colorado, these are for us policy people, some of the grant programs that are available. All of these are open to fund CM. Most of those on the left aren't open right now. I think 1287 is a rural grant program, and I think it opens again in the spring. 202 opens again in about August, and that's kind of a general behavioral health grant. So these are not only open to Medicaid providers, they do favor people who have mostly Medicaid and uninsured folks. The middle one is raised, so those are Medicaid plans. Definitely talk to two Medicaid plans. Both of them are very open to funding contingency management, and they also our Medicaid plans also run commercial arms, and so that would also include commercial insurers. So bring your policy and protocol and a financial proposal to a payer and try to get them to pay for it. We do help with that. Steadman Group does. On the right, upcoming CM pilot. I've struck out a couple times, I'll be honest with you. We didn't get a pilot project with lots of money. They are funding some programs that do community reinforcement approach and family treatment for contingency management through state opioid response. They are also funding MAT expansion clinics. So there's a few rural clinics that have MAT expansion dollars from state that are getting funded. So there is some state funding, but it's pretty limited. And so, self-funding, I didn't put that on here, but a lot of the commercially focused programs are self-funding, and there's still grants open, even if you are not primarily Medicaid. And so happy to talk more about those. There's a lot of behavioral health administration grants out right now. They don't specifically list contingency management. You could apply for funding through those. Next slide. Okay, so the biggest thing, if you're interested in this, start a conversation. It needs a champion. Right? That's where we've seen it work, is where we had a physician or clinician champion with a little bit of time to work on it. And so that's an important thing, is try to get 4 hours a week or so to start to work on the administrative aspects of this, start to put together a proposal, talk to payers, define your population, and put together a policy and a protocol and get payers. Those are your first two things, I think. Upcoming funding opportunities, I mentioned a couple of those, but like I said, I think that the biggest and most sustainable one is our health plans, right? And they have a reason to be interested in this. And so if you go to them with a proposal, I think this has gained enough traction where it's not going to get laughed at. I've not yet been laughed at by a network relations person or a community engagement person yet. They're interested in doing better on behavioral health. This is becoming more, as Steve and I were talking about, becoming more salient in the public's eyes because people are dying from overdose, and they're dying from overdose not just of people who have severe opioid use disorder, but people who are misusing powders, pills, cocaine, and so this is going from just opioids, or mostly opioid overdoses, to stimulant overdoses. And that I think is triggering some people to think more broadly about treatment, earlier treatment, and treatment for substances outside of just opioids. Next slide. All right. So like I said, some of these resources are free. I think we actually have these on our website, on our blog. We have some webinars that go a little more into depth on the basics, on the clinical and the regulatory aspects of this. So happy to offer up all this stuff. Check out our website, check out our blog. And if you have any questions, you can feel free to email me. Pretty busy through the rest of the year, but I'd be happy to talk more about your program. And mostly I just want to encourage people. I was at a conference last week, and sometimes I feel like overdose is going up, things are going to hell, and there's nothing we can do about it. But that's not the case. They talked about 3 big policy wins in Colorado specifically, just in our, not just our lifetime, like my adult lifetime, health coverage has uninsured rate has decreased by about 2/3. Smoking has decreased by like 70%, and teen pregnancies decreased by 83%. So we can do this for overdoses, big outcome like that in, it's not going to happen in a year, but this could happen in 5, 10, 20 years. And I think contingency management is a part of this. It's a really effective treatment that's not applied and is not used in most settings. So there's obviously going to be a multifaceted approach to a big problem, but I think contingency management on the treatment front is a big part of that. So I encourage you all to do this, pick up a contingency management program at your facility for your population for whatever substance, and then do it for everyone. So we've got about 5 minutes left if anybody has questions.
And feel free to type those in the chat or the Q&A box, whichever you'd like. We see them both, so feel free. I did have 4 questions, but your barrier slide answered all of them for me, mostly related to the stigma side of pushback on this. You talked about who are the most who want to push back on this in those cases. Who do you find are the most receptive to this? Who are the most willing to adopt this and give it a try?
Yeah, we have some programs, and it's actually been, the champions have been in our programs really evenly split between clinicians and physicians. I think there's been an MD, PA, then a couple like LPC or LACs have been the leaders. So our receptive folks have been mixed between physicians and clinicians, which probably means it's more prescribers, just given that like it's a clinician dominated field. And I think the stigma, the stigma we get, I'd say the people in recovery were definitely biggest on stigma, because a lot like you saw with medications for opioid use disorder, there's this like hardcore abstinence-based group of mostly 12-step folks who there wasn't contingency management, there weren't medications for opioid use disorder, so they got it's like me in residency. Like I went to residency like 8 hours a week. I want everybody to have to go to residency 8 hours a week, and there's no reason for that. It's just because it's what I did. And so I think that's where we got the most pushback, with people who are like, well, they should just go cold turkey, right? And that's people in recovery's viewpoint is super valuable. In fact, it's the most valuable, but also it's not keeping with the evidence, right? That this does work. And you can say whatever you want about stigma or regulatory, it works. And so we need to find a way to do this.
It's funny you mentioned that. I was thinking, as a member of one of those 12-step communities, oh, this would be great if we could somehow work this into what we do, and just head spinning of how much pushback we would get from even suggesting. Forget the logistical side and the debates about it, just the pushback from the regular folks would be just absurd, not amazing.
And I see, Joanne, thanks. Sounds like you moved a step toward contemplation or action on this, right? Yeah, it's about keeping people in treatment in those first few weeks or months, where I was just talking with a client who's a opioid use disorder treatment provider, and they lose so many people. Literally lose them like dead. Leave treatment because of the difficulties with inductions, because of overdose. Literally, like people missing an appointment and then they don't show up to their next appointment because they've died. So keeping people in treatment is more important than ever. And this is a way, this is doing whatever it takes. You need to keep people in long enough to get that induction done. If it's medication, to get them to start to think, use some frontal lobe, right? After 4 weeks or 8 weeks. And then, people start to think, gosh, $20 really isn't that much money, right? It feels better that I go to work full time, or it feels good that I have a relationship with my kid. And they start to realize that, there are things out there worth more than money, more than drugs. And yeah, that clear-headedness is it's a necessary first step to get to those other steps, right? You can't, like, one of my sponsors told me, he's like, do you know, you know what step 0 is? And I was like, no, there's no step 0. Step 0 is stop using drugs, right? It's really hard to think about things beyond drugs when you're using them, right? And so the first step, the second step, all that stuff doesn't matter. And that's just not for 12-step, right? That's for therapy and things like that. You can't engage. I tried to engage in therapy when I was like deep in use. It just doesn't work. Great. Joanne, great point. A lot of people are like, well, this is new. How do we know that it works? It's been around for ages and ages and ages, since the 70s. And it just has never hit the big time because of all those barriers that we talked about. So if somebody ever says, well, we need to have more evidence to know that this works, you don't. It's been a long time. And so that's one barrier that I won't, I will address, but I won't give serious time to, because this has tons of evidence. It works everywhere and it's been around for a long time. So I know we're over time. I hope this was good use of your lunch break, and really appreciate everyone thinking a little bit more about contingency management.
Thank you very much for taking time out of your day. I know things get busier on the holidays for everyone. Very much appreciated. I'll send out the emails with your CEU certificates either later today or first thing tomorrow, along with the Zoom link. Thank you again so much. And I hope the rest of you have a great week.
Bye, everyone.